I think we're going to find that in like another 5 or 10 years, we're going to get a note from Nick with some demands. And say, Chris Gill, I want the following.
Welcome once again to Free Associations from the Boston University School of Public Health, the only public health and medical journal club podcast for anyone who is as confused by the latest health study as I am by bears.
Bears?
So, bears.
Chicago Bears?
You mean like the aspirin manufacturer?
No, I'm talking about I go away for 6 months and there is a bear that is wandering around
I saw that.
my hometown of Arlington.
Was that close to your house? It was up in a tree.
It was the other side of town. But, I mean, we live not in the city, but we live in a city.
Yeah.
How is it we have bears wandering around?
I don't know if you recall, but there was a similar fascinating story of this bear that had wandered down from New Hampshire, presumably, and had found its way through the western suburbs and then had gotten all the way down to the Sagamore Bridge, crossed over the Sagamore Bridge and walked along all the way to the end of Cape Cod until he finally got to Provincetown, where he was nabbed and put into a cage and transported back to New Hampshire. He was back 2 weeks later in Provincetown.
Oh.
Looking for taffy.
Looking for
Saltwater taffy.
Right.
And there was a bear that was on a tree hanging over the Massachusetts Turnpike, too.
Really?
Yeah.
When?
That was several years ago.
Oh,
they had
amazing.
to actually sedate it and get it and drag it off so it wouldn't fall on top of a car.
Oh.
Wow.
Well, in case you are unaware, I'm Matt Fox from the Departments of Epidemiology and Global Health, and I'm here as always with Chris Gill and Don Thea
From the Department of Zoology.
from the Department of Bears. And
Or zoology.
they're in the Godly studio, but I am still, this is probably my last episode, which I will be taking, maybe one more. I may be able
We're
to
really
do
going to
one
miss
more.
you, Matt.
From the other side of the pond.
Yeah, I may be able to do one more in, 2 weeks or an hour, whatever it is.
Or not.
From old Blighty.
Whatever it is. Anyway, so it's Summer Institute time at the Population Health Exchange, isn't it?
It is.
Am I right about that? So
You are.
anyway, they got a lot going on there, but if you missed out on that, you can still check out all the great things going on at the Population Health Exchange at www.pophealthex.org, our resource hub for lifelong learning. And also, if you could go give us a rating on iTunes, we would really appreciate that.
With a review. Nobody has put in a review since February.
And 5 stars.
We're
please.
feeling ignored.
Chris, are you doing Mr. Subliminal there? 5 stars, 5 stars.
Exactly.
Anything you want to give us, 5 stars, 5 stars. Have we not offered anything in a while? I think that's why. We get ratings when we offer things to people. Anyway.
Maybe we should offer umbrellas.
Great idea. Don't know why, but
People
it sounds
like
like a great
umbrellas.
idea. Well, so now on to the show. So today in our first segment, which is our Journal Club segment, we are going to look at one that's big news in our world. It's a study of HIV transmission among people who have been successfully treated for HIV. And then in the second part of the podcast, which is our deep dive, we're going to talk about what we mean when we talk about risk factors. And then in our third segment, which is our amazing and amusing, we'll get into some things that make us laugh out loud, or I will just whine about the size of my wine glass. That was clever, right? I'm getting nothing from you guys. Complete dead silence. Wow. Okay.
All right.
Let's do it. Segment 1. So we're going to talk about an article that looked at the impact of HIV treatment, effective HIV treatment, on transmission of the HIV virus. It was published in the journal The Lancet, and it was entitled Risk of HIV Transmission Through Condomless Sex in Serodifferent Gay Couples with the HIV-Positive Partner Taking Suppressive Antiretroviral Therapy. That is a mouthful, and I'm not even done yet. So that's the partner study, final results of a multi-center prospective observational study. That's got to be one of the longest titles I've read in a while. It's by Alison J. Roger from the Institute of Global Health, right here in merry old England in London, the University College of London. And as I said, this is a real big deal in the HIV world. So here are some of the headlines. So the medical news says, "Stop the stigma. HIV transmission with suppressive ART is zero." CNN says treatment eliminates risk of passing on HIV. National Global News says antiretroviral drugs stop HIV transmission, study shows, but can people afford them? Which I thought was an interesting question to add on at the end. Then Yahoo News says landmark HIV study finds that treatment lowers virus spread to near zero. So Don,
In fact, zero.
What's that?
And in fact, zero.
Yeah. So Don, what? Tell us what this study was about, and if you can, why it was such a big deal.
Yeah, this really was an important study. This study has and will have major impact on public health programs to interrupt transmission of HIV. And it's important to understand that this was the second part of a study that had previously been published that went a long way but didn't go the complete distance to proving the fundamental point that's outlined in this paper. The first study that I alluded to, which this was an extension of, was a study called Partner 1. And it was essentially the same investigators and the same population. And what that study did was to look at the likelihood of transmission among a combination of heterosexual and gay discordant or differently infected individuals, where one is infected and the other one is not infected. And in that study, they found that there was no, quote, linked transmission, and I'll come back to that in a minute, in 888 couples, 548 of which were heterosexual and 340 of which were gay discordant couples. And that was in a population that was relatively small for them to be able to determine whether the effect was what they would like it to be, i.e. very low or zero transmissions in the gay population. So building upon that, they designed this study, which basically extended the observations of Partner 1 amongst the gay couples, and then enrolled a subsequent cohort on top of that at a somewhat later date in a similar fashion to really extend the observation and try to have sufficient power to be able to make these observations with high rigor in a gay population. So Partner 2 is an observational multi-center study of serodifferent individuals in gay relationships who had previously not been using condoms, been having condomless sex, who were in a relationship with a partner who was HIV positive, who was on ARVs, and whose viral load was essentially below the level of detection. So they were fully suppressed. This occurred at 75 sites in 14 European countries, and they were followed up for a period of time. I think on average it was 1 to 2 years.
I think the median was maybe 2 years.
2 years.
Yep, it was 2 years.
And that once they were enrolled, there were visits. There was a baseline visit, and then there was a visit every 4 to 6 months. And the individuals in the cohort self-reported on sociodemographics, adherence to ART, frequency and type of sex between the partners since the last visit, symptoms and any diagnoses of STIs or sexually transmitted infections, whether PrEP, which is pre-exposure prophylaxis, or post-exposure prophylaxis, was used. That is, using antiretrovirals in anticipation of having an episode of condomless sex, or taking antiretrovirals if you were the HIV uninfected partner and you've had sex with somebody whose status is known to be positive or unknown, taking antiretrovirals afterwards. So the HIV negative partners were also asked if they had condomless sex with anyone else outside of the relationship during the prior interval. And the HIV partner had to be on an ART regimen. The CD4 counts were recorded, as well as the current and recent viral loads. And the HIV negative partner was tested at each visit. And if the HIV uninfected partner developed an incident HIV infection in the interim, that virus was then harvested, and it was subject to extensive phylogenetic analysis to essentially establish whether, in fact, the virus that was newly infecting the previously HIV negative partner was the same virus that was infecting the HIV positive partner in that relationship, because there were episodes of people having sex with others outside the relationship. And that was, I think, one of the real strengths of this study, was that it was able to say that of those events, of those infections that occurred under the period of observation for these couples, they were able to say whether that infection resulted from the index partner, the HIV positive partner, about which viral load and an HIV infection status was known. So it was a really important part of this. There were intervals that were deemed ineligible. So there are periods of observation during which they did not include information from that interval. And those were intervals during which the following occurred: that there was post-exposure or pre-exposure prophylaxis that was used sort of outside of the normal dynamics of the study, that the negative partner reported no condomless sex, that the most recent viral load was over 200. There was no viral load available in the past year. Data on sexual behavior was missing, or no HIV test from the HIV negative negative partner. So they're really looking for all of those intervals which really were refined to this central dynamic of the HIV-infected partner having a confirmed viral load that was below the level of detection and that there was condomless sex during the interval. So they had a total between partner 1 and partner 2, the two studies that were back-to-back, 972 gay couples were recruited. There was 2,072 couple years of follow-up by the end of the study. There was some dropout, most of which was due to the couples breaking up. So they would not be followed any longer if the incident couples had broken up and they were no longer having sex during those subsequent intervals. There were 479 couple years that were ineligible because no condomless sex. There was 32%, use of PEP or PrEP, 24%, viral load is not available in 18%. Missing data on condomless sex in 19%. So there was a smattering of different reasons why these particular intervals were deemed ineligible, which left about 1,600 couple years of follow-up by 782 couples with median, as Chris said, follow-up of 2 years. The baseline results in terms of the two populations of individuals were pretty unremarkable. People had the HIV-positive partner had been in ART for a median of 4 years. There was incredibly high compliance and incredibly high accuracy in the reporting of the compliance.
Yeah, really high.
One of the things to say is that it was a pretty specialized population because it was a white population. It was a relatively wealthy population. I think there were relatively few non-whites and there were relatively few IV drug users. During the period of observation, about 27% of the population got a sexually transmitted infection, and that actually is fairly important. 37% of individuals had condomless, of the HIV uninfected individuals had condomless sex with another HIV-positive partner, and there were about 43 condomless sex acts per year, and they observed essentially 76,000 condomless sex acts in the entire population. And the bottom line is that there were 15 HIV-negative partners who became infected from this population, none of which were established to be from the HIV-positive partner based on a phylogenetic comparison.
Zero.
None.
Nada.
So there were 6 additional conversions which occurred during ineligible intervals. So those actually could have been conversions or infections that had occurred as a result, but we just don't know. And the authors chose to remove them from the analysis, which I think is the conservative thing to do. So that 0 has a little bit of uncertainty around it. But the bottom line is that they estimated that there was about 1 seroconversion event for every 435 years of condomless sex in this gay population, which is really remarkable.
Mm-hmm. Unbelievable.
I mean, I think that's the bottom line. And,
very impressive.
It really supports the whole contention that if you are
Undetectable.
undetectable,
Undetectable equals
you are
untransmissible.
uninfectable or uninfectious.
Yeah,
Infectious. Yeah. So a major take-home message for the public health effort to really decrease transmission in populations.
Yeah, totally agree.
I mean, a really impressive demonstration of the fact that if you are HIV positive, you are taking your medication and it's effective, meaning that you are adherent and it is suppressing the virus. We cannot detect it in your blood. There is virtually no transmission that can occur to uninfected partners. And this follows on from some previous studies, one of which was the landmark HPTN 052 study, which had shown essentially the same thing in sub-Saharan Africa. Well, actually, it was all over. And it found a 97% reduction in transmission before they had actually ruled out any unlinked transmission. So this is.
But that study had only 2% MSMs, so it really you could not extrapolate to that population.
Absolutely.
Right. And we should emphasize that in epidemiologic studies that have looked at the force of infection risk based on mode of contact, that unprotected receptive anal sex is the highest risk of all sexual exposures.
Absolutely.
Other than drug injection, presumably.
Right, but that's not a sexual exposure. But yes.
Sorry.
Yeah.
Of course. So Chris, give us your take on this study, but in particular, I want you to just think about the fact that this, unlike every other study that we have looked at, did not have a comparison group. And I'm curious your thoughts as to why they didn't have a comparison group here, but also your general take on this study.
Yeah, sure. So maybe I'll start with the addressing your question, Matt. So they did mention this somewhere. It was either in the intro of the discussion. I don't exactly remember where, but they do have a base case against which they can compare, because we have had decades essentially of a natural history cohort of what happens when there is uncontrolled HIV viremia and the consequence of that in terms of sexual transmission within couples. And, so their base case scenario, which they're comparing about, is that you would have expected, if these individuals were not undetectable, that the transmission rate would have been around 50%, just slightly lower than 50%, but, we can say approximately 50%. And so they would have predicted from this cohort that instead of 0 transmissions, there should have been around, just shy of 300 transmissions. And so it felt like, here really you didn't need a control arm. I mean, we talk about selection biases and why, randomization is important, but all of that is, I think, generally because we fear, selection biases that may be, important, but on a relatively subtle scale, like maybe it skews you 5-10% one way or the other. But here, the magnitude of the base case is just so extraordinary that to have a 0 transmission rate, I mean, I think that, you don't need to be, the evidence is pretty darn persuasive. I mean, let's be clear here.
Yeah, but I think there's still there's sort of a quirk to that particular observation. And one of the things that struck me about this was that they had 19 couple years that were deemed ineligible, but they determined that the viral load was above the 200 threshold, and the range was 202 to 170,000 in those 19 couple years of follow-up. So these are intervals where there was a detectable viral load, and there were 810 sex acts, but no transmissions during that period of time. Now, that may be due to small numbers, or it could be due to some residual effect of having drug on board, despite the fact that you're not fully suppressive. So there may be some kind of halo effect that could be occurring in addition to that.
Right. I mean, mechanistically, why would we expect it to be an all or nothing affair? Right?
Yeah, it could be that these are non-viable viruses because they're swimming in a pool of antiretrovirals. So, even though they're there, they can be measured by PCR. They're not infectious.
Right, and some of this may also be virus that's nested within lymphocytes and is not free virus.
Correct.
So there are a lot of reasons for that. But also, presumably, the absolute magnitude of your viremia is critically important. It's like there's a heck of a difference between 400 copies per mil and 4 million copies per mil in terms of your contagiousness.
Absolutely, yes, absolutely.
So I had a couple thoughts about this study.
Before you do that, can I just speak to the control arm issue, which is that I hear you and what you're saying, and I actually, in the end, I actually do agree with you. Although I would say that the reason we have the control arm is because it's possible that things go differently from our expectation, and it could be that nobody in this population is actually having condomless sex despite what they're telling us. And so the comparison arm would be there to tell us that actually we're not seeing any transmission in the arm that isn't taking suppressive therapy. But where I agree with you is here, I think the point is that the magnitude of the effect, the expectation is no transmissions or very few transmissions in the arm that is suppressive. And so what we're really trying to do, as they say, is they're trying to get a confidence interval around 0. Yeah. Which is neat. It's something I've not seen before.
Yeah, I would love it if we could loop back to that issue about the confidence interval, because that is for from an epidemiologist perspective is interesting. But I also wanted
nerd candy.
It's nerd candy, yeah. But there's a huge issue of ethics here, right? I mean, one couldn't really, we cannot claim clinical equipoise that
I was not arguing for a trial. I was not
no,
arguing for a trial. This would have to be an
impossible to do this as a randomized controlled trial. For obvious reasons.
Never.
Yeah.
Sorry, Chris, I interrupted you. Go ahead.
Yeah. No. So, but there was an interesting internal control, and this was one of the points I wanted to raise, which was the very high rate of STIs within this.
It's amazing.
Within this couple. So obviously. I mean, I say that obviously, but maybe I mean too bold. But the high, there was something like 23, 24%, some roughly a quarter of the seronegative 27% acquired gonorrhea, syphilis, herpes, or chlamydia during the study. And so that tells you that there's probably, almost certainly, condomless sex going on in the couple and outside of the couple, because other diseases are entering into these are not in many cases, obviously they're not monogamous.
Yeah.
Because they're having sexual contacts. In fact, a lot of that was documented in the study that they said that there was quite a high rate of extra-couple sexual contact. But the high rate of STIs would suggest that this is, in fact, maybe an underestimate of what people were admitting to in the trial.
So it could be, you're right, although it could be that having sex outside the couple is actually a less risky event than having sex within the couple, because you know that the person in the couple is HIV positive and the person outside could be HIV negative. But the point here is that because the transmission is effectively zero, it's actually riskier probably outside the partnership than inside the partnership.
Right. And that was one of the interesting things that came out of the study, that the 15 infections that did occur were not genetically linked to the HIV positive partner's HIV strain. So these were strains of HIV that clearly came from extra couple contacts.
I think the other interesting aspect of the STIs is that we know that the presence of a sexually transmitted infection potentiates the transmission. And the fact that we didn't, even in the setting of these intervals during which an STI was active, we still didn't see any transmissions, even in that group, is, I think, persuasive.
Yeah, I agree. I hadn't thought of it that way, but you're quite right. Yeah,
I think it's incredibly strong evidence that undetectable equals untransmissible. But I do want to go back to that point, which is, as you pointed out several times, Don, they excluded time periods when the infected partner did not have a suppressed virus, meaning you could detect HIV in the blood, and that is either because one of two things presumably is going on: either they're not taking their medications consistently, or they've become resistant to the treatment that they're on. And so they excluded that. And the reason they excluded that is here what they're specifically trying to do is estimate what's the probability of transmission if you are suppressed.
Right.
But that means that these results, you have to be really clear, only correspond to time periods when the infected partner is suppressed.
Right. There's a lot of ifs here.
Yeah, and so that's really important. Now, HIV treatment is very effective, and so if you're taking your treatment consistently, the majority of people are going to have a suppressed virus the majority of the time. So this is, it's an effective treatment. It's going to work most of the time, but it is important to stitch that caveat into this.
Right. So when we talk about undetectable equals uninfectious, we have to be really careful that we're not saying on treatment equals uninfectious.
Exactly.
That is not the same. The two are not synonymous.
And I think it's really important to stress the fact that you have to presume that it's going to take at least 6 months once you initiate antiretrovirals for you to become undetectable.
Yeah.
So people who are newly initiating on treatment absolutely need to either abstain or have condom-full sex.
Not a word.
Condom-full sex.
My spell checker doesn't like condom lists. It definitely would not like condom full.
One other thing I wanted to highlight in this is that this issue about achieving undetectability of HIV and as having this be a key part of our strategy in controlling the HIV pandemic, is treatment alone going to get us out of the HIV/AIDS crisis? And I think
No.
there's still a lot of debate about this issue. And one of the things that they mentioned here, it's kind of a subtle point, but I think is worth mentioning, is Matt still there?
I'm shaking my head no.
He's not here. He's left. Is that the average age of the men in this cohort was about 38 years.
Right.
Yeah.
And the average age of men who become infected with HIV is 25 years.
Right.
So that is a huge caveat. This is a 12-year delta from the time that HIV was on average acquired, and so this is not really a strategy necessarily that's going to control HIV transmissions in the population at large. We're really just talking about monogamous couples in whom one member is positive, who is faithful to their HIV and has achieved undetectable viral load.
I would absolutely agree with that. I would also say that we think that we know that some proportion of all transmissions occur before the person ever goes on to HIV treatment. It's possible that there is a sizable chunk of that is actually happening during the period just after their transmission.
That's right.
So the period that they become infected. We don't really know that as well as we probably should.
Right.
And so, this only only deals with the time period from after which you have gotten onto treatment. And as Don says, you pass the period at which you are unsuppressed. So we're not going to be able to treat our way alone out of this epidemic, but it is a really important piece in the toolkit that we have.
Right. It emphasizes the absolute criticality of suppressing the viral load as a tool at a population level for reducing transmissions. But it also, I think, steers us back to the importance of pre-exposure prophylaxis. In fact, on the drive in this morning, I was listening, sort of catching up on my daily podcasts, and they were talking about, the sort of pivotal PrEP study that had been done in the United States, sponsored by NIH, with drug donated, Truvada donated by Gilead a number of years ago, that showed a profound reduction in transmissions if you use PrEP. And in fact, if we can plug another podcast, I think this episode was really interesting because it was not just about like, wow, we have this tool, and yet we are not using it, because there's apparently about 1 million individuals in the United States alone for whom pre-exposure prophylaxis would be warranted, and only about 250,000 or so are actually taking PrEP. And a big barrier to that, unfortunately, and this is a bit cynical, has been the very high cost of drugs driven by the drug company Gilead that is making this. Apparently, this came out in the pod, so I can state this is now public domain knowledge, but it costs $60 per course to manufacture Truvada, and they are selling it for $20,000. $60 actual, $20,000 market upgrade.
What was the podcast?
This is the daily podcast put out by the New York Times.
Right.
Yeah, it's a very depressing story, and it is basically clear that it is the high cost of Truvada is the key barrier that's stopping this very effective strategy from being rolled out more generally.
That's amazing. And to be clear, that if I had Michael Barbaro's voice, we would be the number one podcast.
I was thinking the opposite. He just we need to upgrade to the Matt Fox velvet tones.
So before we leave this study, I don't want to let this one go. I mean, so we haven't really totally critiqued it, because so this is not so as we said, they're just trying to estimate a rate here of transmission. So there's no comparison, which means there's no confounding problems, right? You just have one arm. You don't have anything that is potentially confounding. But I do wonder about issues of selection and issues of measurement, which are the two things that could still, potentially screw up the estimation of that rate. Measurement, I don't think, probably not a huge issue. I suppose you could
specifically measurement of what are you referring to?
Everything. I mean, measuring the outcome, so measuring HIV, probably pretty good. Measuring condomless sex acts,
yeah, that would be the hard one.
Might not be so great. So we don't necessarily know that, but it's probably not going to be a big deal. I do wonder about selection, though, because there was a fair bit of dropout in this study. So it was 25 per 100 couple years of follow-up, if I got it right.
That's high.
Much of that was couple breakup, right? So it's not because, they just lost interest in being in the study, or they were more likely to be at risk. It's the realities of doing a couple study. They are no longer in a partnership. You can't continue to study that group. So I think it probably doesn't really matter, but I just think it's worth highlighting.
Mm-hmm. The other thing is, of course, eternally difficult to measure is adherence, particularly by self-report. But here, I guess...
But didn't they confirm that? Didn't they confirm that comparing stated adherence with viral load suppression, that there was a very high level of adherence, and that
well, in this case,
underscored the veracity of what they were saying.
In this case, I think it was almost circular, because one of the inclusion criteria is that they had to be undetectable.
But they had to sustain that also.
But they had to sustain that. But once you have sufficient adherence to become undetectable, it's likely that your adherence is going to remain fairly constant over time.
Hang on, but they excluded the time periods when they were not suppressed. So I'm not sure it's relevant.
So it becomes a moot point. It's not a moot point, but a definitional issue.
Right, exactly.
Right. They took them out as removed them from the denominator of time at risk.
Yeah, exactly.
Yeah.
All right. Any last thoughts on this one before we move on from what was, I think, is a really important article?
Yeah, I was just struck by a sentence that was written in the conclusion at the end of the study, which I think underscored sort of where we are with respect to this issue. And it said, despite all the concerns about potential risks, there has not been a single verified case of HIV transmission in the context of complete virally suppressive ART reported in the literature. You got to take that with a grain of salt, but that's a pretty bold statement for the authors to make. And, I think I don't disagree with it necessarily.
Yeah, what was it, about 2000, I don't know, 2009, 10, 11, somewhere in there, that the Swiss statement came out, which said essentially that they believed, these doctors believed that if you were undetectable, you could not transmit. And it's taken until, well, the HPTN 052 study was 2014, 13, 12. I can't remember when exactly that was. And now we have more and more evidence to say that this is correct, which is amazing. It's really, really amazing.
Yeah, the other thing that I thought was impressive was that they closed the study down in April of 2018, and then when was this published?
Yeah.
Very shortly thereafter, which is something to commend the authors to get this really important public health message out.
All right, let's move on to our second segment, where we are going to talk about an article, and this may seem a little strange that for our second topic, we are going to talk about an article from the BMJ Christmas edition from back in 2016, and the article was entitled, "Is Caviar a Risk Factor for Being a Millionaire?" by Anders Hutvelt. And, it's a article that comes from the BMJ Christmas edition, so obviously it's a tongue-in-cheek type article, but it is actually a serious article that makes a fantastic point. And the way that I came across this was people throwing this at me on Twitter, including it was Anders is on Twitter and chimed in a bit on this when I asked the question, what do people actually mean when they use the word risk factor? So when people use the word risk factor, are they talking about causal? Are they talking about just prediction, association? What are we talking about? And I brought it up on Twitter because this is a question that whenever I'm teaching and a student will say something is a risk factor, I always stop and say, okay, what do you mean by that? And I don't mean it in an accusatory way. I'm not sure I ever know what I mean when I use this term. So he tries to make this point that, well, so I didn't know this, that the term risk factor actually came out in the 1960s. It's right here, right there, where you guys are in Massachusetts through the Framingham Heart Study. And it immediately became a very unclear concept as to what we meant when we talked about risk factors. So Anders talks about essentially 4 different ways we can think about what a risk factor might be. So he talks about diagnosis, prediction, treatment, and etiology. So diagnosis meaning we want to predict what's actually happened, past, essentially past tense or present tense. Prediction, where we want to predict the future, what will happen. Treatment, or an intervention, so the idea of what will happen if we intervene to change the situation. And etiology, what are the causal relationships that govern the associations?
Yeah, and I think, Matt, it behooves us because I think this was such a witty and clever article, to actually go through the Caviar Millionaire analysis and summarize each of those points.
Go for it.
Starting with diagnosis, what is the relative risk of being a millionaire if you are seen eating caviar? So you can do that 2 by 2. You have the people who eat caviar and don't eat caviar, and the people who are millionaires and who aren't millionaires.
Sorry, which cell are you in, Chris?
I am in the non-caviar, non-millionaire cell. That would be cell D for deficient. Whereas A would be aspirational.
Right.
Got it. Is that what those stand for? I never knew.
So, yeah. So, you can calculate a relative risk and you'd find that, and I'm sure it's probably true, that the relative risk is huge for being a millionaire if you are a caviar eater. But that is separate from whether eating caviar will make you into a millionaire.
Or a prior millionaire because you've eaten too much caviar.
Exactly. And so then you go into the prognostic, right? Which is like, if I eat caviar now, will I, and consistently in the future, will that help me become a millionaire in the future? And so that's
through what mechanism?
Exactly.
Sorry,
now we get into the whole issue of biological plausibility and causal loops.
Hang on. That would be an intervention.
That would be a randomized trial. But I think he was talking about prognosis as like a cohort study. Like, what is the future of caviar eaters versus non-caviar eaters, as opposed to what is the association today?
So the difference would be if you see somebody eating caviar who is not currently a millionaire.
Right. Will they become a millionaire?
Will they become one?
Right. And then if that looks good, so now we've gone from case control study to cohort study. Now we're going into the experimental study, we're going to say we're going to randomize people to caviar versus no caviar and see
if
how
they
many
become
millionaires result within the next 5 years.
Only those who own the caviar company.
Right, exactly. And here he talks about, like, if this was a non-sponsored study and the people had to buy their own caviar, that you might see an inverse relationship that eating caviar is going to bankrupt you and not make you into a millionaire.
So clever. It's just so clever.
And then the last one was the etiologic fraction, which is like assuming there's a relationship. What proportion of millionairehood can be attributed to caviar consumption as opposed to other forces? and the funny part of this is that every one of those can be expressed as a relative risk.
Right. Or a risk factor.
But yet they're totally dissimilar. It's so clever. I loved this paper.
Yeah, I thought it was fantastic, and I would disagree with you about the designs of the study. Everything else, I would agree with you on there. So the point that it makes for me,
because it might matter the kind of caviar you eat too.
Obviously, I think we all know that is true. But if you hear somebody talking about something as a risk factor for something else, smoking as a risk factor for lung cancer, do you know what they're talking about?
No. I don't, and
especially after reading this article.
Especially after reading this, because it occurs to me that lung cancer is a risk factor for smoking.
Well, so right, if you were to do it in the predictive sense or the diagnostic sense, yeah, I would
Or a kayak,
think that would be true.
Or a kayak on top of your Subaru is a risk factor for vegetarianism.
Exactly. Vegetarianism is a risk factor for kayaks, apparently.
Okay. So then I would ask the question.
Both of them are equally ridiculous. And that is the point. And yet we see such papers published all the time without a hint of irony or maybe self-awareness.
Okay. So when you see this language in, when people talk to me and use the language risk factor, I'm not totally clear on what they're talking about. How about when you read a study? Can you tell what they're trying to get at when they use the term risk factor? Whether they're talking about, because now you have the context of at least the study.
Usually not.
Yeah, I have to go back and rethink that based on the way this has been etched out. I mean,
I'm also feeling very self-conscious right now.
Because you use the term.
I suspect that I'm as guilty as the rest.
I suspect I am too. But what I think makes this worse is the fact that we hide behind associational language in publications. So we are very shy about ever using the word causation because we have been trained that, unless you've done the perfect randomized trial, you can't easily assess causation from observational data. So I'll use the word association. Well, to me, association is just as bad as risk factor because what I don't know is what was your intention.
Yeah. And
if we started off studies, so I'm totally fine with the idea that we refer to the measures that we get from our epidemiologic studies as measures of association. That's fine by me. But what I want to know is in the introduction, in the method section, what are you intending to measure? Mm-hmm. Are you intending to measure an association or an effect? If you're intending to measure an effect, then I'm expecting I'm expecting a certain set of procedures that it will at least try to get me close to causation. If you're trying to get at prediction, then make it clear to me why you're adjusting for all of these things when, for prediction, I just need to know, is that variable associated with that outcome if I want to use it for prediction? And then people say, well, we adjusted for all these other things. Well, if it's just prediction, why? And it becomes really difficult.
You should explain that point a little bit further because that's a bit of a subtlety.
And it's pretty fundamental too.
Yeah.
Yeah. So if you want to know whether or not carrying a pack of matches is going to predict, let's say, lung cancer, we would expect that if you're carrying a pack of matches, that your chances of developing lung cancer sometime in the future are higher than for people who don't carry a pack of matches. That is completely confounded by the fact that people who are carrying matches are more likely to be smokers. But if I'm looking at prediction, I don't want to adjust for smoking. I just want to know, is asking people whether or not they carry a pack of matches a good predictor of the outcome?
Right. If
I adjust for smoking, then that association is going to go away, and you would say, well, then carrying a pack of matches doesn't tell me anything.
It ceases to function as a useful screening question because
so you don't want to adjust for confounders if what you're getting at is prediction, unless you have some complex prediction algorithm you're trying to build. But then, my second question then becomes, what are you going to do with this?
Right.
But, those are two separate goals, both important. Assessing causation and trying to predict the future are two important goals, but they have different methods behind them.
Right.
Let's be clear about what we're trying to do is what I'm arguing for.
It's not exactly the same thing, but it struck me as that the paper that we reviewed a couple sessions ago that was talking about, I think it was marijuana and psychosis, that they had sort of wandered into this area of etiologic fraction when the study had initially started out as trying to, I guess, diagnose schizophrenia, where it was a prediction.
Right.
But they had done.
They were trying to say how much psychosis would be removed from the population if nobody was consuming marijuana.
Correct. Right.
Yeah.
Right. And yet the original study design was a cohort study, and so I'm wondering now if this is an example of where those distinctions blurred a little bit in the analysis.
Well, yes and no. I mean, I think what you're trying to say there is it was a cohort study, therefore they couldn't assess cause and effect. I would disagree with that. So I would say you can get at causal measures from observational data, but you have to be really careful and do it really well. But I take your point. I mean, I think they were veering into an area that that they couldn't really support.
Yep.
And so the last point I want to make on this is the other place where this seems to me there is inherent contradiction, and I think Anders makes this point as well, is you will see studies that will say association, association, association. You'll get to the limitations, and they'll say, it's observational data, and we have these problems, so we can't say causation. And then they'll tell you the policy implications.
Mm-hmm. Anyway, yeah.
How can we get policy implications if we're not looking at causation?
Yeah.
I mean, I suppose you could if you were really saying this is prediction and here's what you could do with it. But that's not what they're saying. They're saying, essentially, I'm going to tell you that none of this is causal, and then I'm going to tell you why we should actually act on this, and it must be causal.
Right. And then this is where, let's pass a new ordinance in the city of New York to take out salt from foods at all restaurants is going beyond the association and straight to assumptions about causation. And maybe it's true,
Yeah.
maybe it isn't. But, it was a bold leap to go from the epi without showing, with any randomized controlled trial data suggesting that high salt versus low salt actually changes cardiovascular outcomes. In fact, the only randomized controlled trial I'm aware that has looked at salt as a risk factor, as an intervention, manipulating salt as an intervention to change cardiovascular outcomes, actually showed an increase in cardiovascular outcomes when they reduced salt.
Yeah.
So, here we are way off the range, I think.
I think you're right. Any other comments on this one before we move on?
No, thoroughly enjoyable paper.
Yeah, so funny.
Yeah, so well done. And what I love about it is a paper that makes a really, really important and clever point and does it in a funny way. And I think that actually gets people to read it and pay attention to it. So well done.
Yeah.
Well done, Anders.
It's
Good
a
job,
fantastic
BMJ.
paper.
Well played.
It was a
And well
Christmas
done,
issue
Anders.
too.
Yeah.
Exactly. Yeah. Okay. So let's move on to our last segment, which is our amazing and amusing. And I'm gonna take the prerogative and go first on this one, and because mine is a pretty short one. It was just something that I came across on Twitter that just made me giggle, and it was a tweet by a guy named Mark Van Gotham. I don't know how you pronounce his name, and his tweet reads: "Trying to be an adult and read a scientific paper, and your wife does this." And then he shows a picture of the paper that he's trying to read, in which the title of the article is "The Influence of Climactic Legacies on the Distribution of Dryland Biocrust Communities." And before the title...
Biocrust communities?
Yes, I don't know why you're laughing at that. That wasn't the,
It's like, what is
that
that?
was the funny part.
All right.
That's the serious article
Okay.
title. The Influence of Climactic Legacies. Anyway, and his wife has written before the beginning of the title, Harry Potter and the Influence of Climactic Legacies.
I love it.
That's
Keep
awesome.
And it
Keep it
occurs to
real.
me that you can do this for so many articles
Really?
because of the way we write our titles. But it turned out, so I went and looked at our articles. So I looked at the three of us, and Don, you and I ours don't actually work quite as well, partly because they're about HIV, and so it just doesn't come across as well. But Chris, a few of yours worked well.
Oh.
Harry Potter and the Effect of Training Traditional Birth Attendants. Harry Potter and the Persistence of Immune Response. and Harry Potter and the impact of enhanced infection control. I love it.
That's good.
You had no idea,
And it
Chris.
goes to the Hogwarts bathroom, which, as I recall, is a very dangerous place. Now we know you should use alcohol-based hand wash.
There you
It'll
go.
keep away basilisks and more.
All right, Chris, what do you got?
All right. Well, I would like to note that all three of us do a lot of work in Southern Africa, and so this is a topic that the three of us will find charming. I just got back from there. So, Don,
As did I.
Matt, right? What is one of your favorite alcoholic beverages that you associate with Southern Africa?
Mosi?
Wine.
Gin and tonic. That's where you're going.
Okay. Yeah, it was, think elephants.
Amarula.
Think, there we
Tusker?
go.
What was it?
Amarula.
Amarula.
Okay, so
Isn't this
why
this is-
why does the Amarula bottle? Okay, I should explain to our readers. Amarula is this yummy. Like Don hates it. Okay, but I love it. It's this yummy cream liqueur that is very similar to Bailey's Irish Cream, kind of mixed with juicy fruit gum. I think that's sort of the best description I can, and it's and it's based on the fermentation of this fruit that lives in Southern Africa called the marula fruit, which is like little kind of hard things with a thick that taste kind of orangey. They're very citrusy and very acid, and they're also sweet and they're delicious. And the reason why they have the elephant on the label, do either of you know?
No.
Okay.
Because they fall to the ground, they ferment, the elephants eat them, and they get drunk.
This is true. Well, this is the story. It may be somewhat apocryphal, but everybody says that this is true. But it is undeniable that elephants love marula fruits. Now, there are two other organisms on the earth that really love marula fruits.
Okay.
What are those?
What are they?
One, you guys can
two
guess.
Baboons.
Think taller.
Giraffes?
Giraffes.
No, stick with baboons. Think taller and smarter.
Oh.
Apes?
Yes.
Gorillas?
Us. Humans. Humans really dig.
Neanderthals?
Humans really dig marula fruits.
enough. Okay.
So we eat truckloads
All
of them. Okay, and there's a third one, which has got 6 legs.
Speak for yourself. I hate gorillas.
6 legs.
6 legs and little tiny paired wings. And it's annoying, and they fly around our office, and they also fly around your kitchen around July.
Moths.
Tiny.
Moths.
Mosquitoes?
Tiny.
Gnats?
Oh, tiny. Gnats.
And they like
Fruit
marulas.
flies?
What is this?
Fruit
Jeopardy?
flies?
Is this
Fruit flies, bingo. Drosophila melanogaster love marula fruits. Now,
Where
Where
is
is
he
this
I just want to
going?
say, I
lost.
did not enjoy that quiz.
okay, so these are sort of the facts upon we're basing this excellent paper that was published in Current Biology Reports under the Cell Press nomiker. This is in 2018, and the lead author was Susan Mansourian, talking about the origins, the coevolution of Drosophila melanogaster, which is the common fruit fly that drives us all nuts, and marula fruits. Now, the funny thing about Drosophila melanogaster, the fruit fly, is that anyone who's got apples or bananas or grapes that they keep in their kitchen is going to have fruit flies everywhere driving them bonkers in the middle of the summer. But you cannot, even though these things are ubiquitous, and by the way, are the most studied organism in terms of genetics on the planet by far, even though these things are ubiquitous, they cannot be found anywhere in the wild except for one place, which is marula forests in the Maponi forests in southern Africa, in Zambia, Zimbabwe, and South Africa. Now, so how it turns out is that the fruit flies had originated living in these Maponi forests where there were all these marula fruits, and these fruit flies have evolved to coexist with marula fruits specifically, and they have very interesting genetic mutations that make them hypersensitive and attracted to the specific volatile compounds that are emitted by rotting marula fruits. Now, the other thing that's really interesting is that that second group of organisms that really likes marula fruits is human beings. And so there are caves in these areas, limestone caves, and this is considered to be the basket of humanity is what they build themselves as, where you go back into the recesses of these caves, and one of these caves contained, I kid you not, approximately 24 million marula pits. So the people who lived in them caves really liked marula fruits.
It's sort of like my easy chair and pistachio shells.
Exactly, or popcorn, right? So you can kind of imagine prehistoric Zimbabwean man sitting there digging their marulas. 24 million pits in one cave alone.
Wow.
They just like toss them in the back of the cave. So you can imagine that there were probably one or two fruit flies back there as well. So it now appears that this was the point where the fruit flies and human beings became commensal. It's through the mutual adoration of the marula fruit. And that as humans then disseminated, bringing their fruit-loving behaviors with them around the world, the fruit flies co-evolved with humans and are now almost exclusively found amongst humans and never in the wild, except still in the Maponi forest in South Africa. It was just it was such a cool story.
That's wild.
Isn't that amazing?
And they're even at Hogwarts.
Those fruit flies are just annoying.
I'm gonna just go out and say that I did not know that was going anywhere. So
But now you're relieved.
I'm thrilled you got somewhere with it.
Thank you.
Well done.
Thanks.
All right, Don, what do you got?
All right, so I have a shout out for one of my students from last semester, Esther Ray, who sent this article to me, and it was one of the most enjoyable articles I've read in a long time. Very, very topical. It is an original contribution that appeared in Injury Epidemiology, a journal I'm sure, Matt, you subscribe to on a regular basis.
I read it every day. I'm also featured in it.
Ryder Lystad and Benjamin T. Brown, and the title is Death is Certain, the Time is Not. Mortality and Survival in Game of Thrones.
Ooh, yeah.
So what they did, these two authors went out and bought the full 7-season DVD compilation of Game of Thrones without the last episodes. They don't know what happened with the last episode, and I'm sure all of our listeners know exactly what happened in the last episode.
I don't.
They went through all of those episodes, and they counted everybody that died.
So it's like a giant survival analysis?
Game of Thrones. They did a survival analysis, and they looked at a whole bunch of risk factors for death in Game of Thrones. And basically, they came up with a number of characteristics that predicted death. So of 330 characters that were included, 56% died by the end of the study period. All but 2 deaths were due to injury, burns, and poisoning. And what they did very clever, they went through all of the deaths and ascribed an ICD-9-10 code.
Oh, that's awesome.
And they have a table that takes up 2 pages with the ICD-9 codes of things like open wound of head, SO1, intracranial injury, burns of multiple body regions, assault by drugs, medications, biological substances, place or occurrence, prison, home, military camp, street and highway, trade and service area. Then what they did is they looked at what predicted death among the characters in Game of Thrones, and the survival time ranged from 11 seconds after introduction of the character to 57 hours, with the median survival time estimated to be 28 hours. And that is of running time of the series, not of like real Game of Thrones time.
Oh, I see. I was going to ask how they coded person time.
The probability of surviving at least 1 hour in the show was 86%. The analyses revealed worse survival for characters who were male,
that makes
who
sense.
were low-born, and who had not switched allegiance during the show, or who had featured more prominently in the show. And they went through this analysis where they have social status, highborn, lowborn, type of occupation, which they stratified to a silk collar occupation or a boiled leather collar occupation. So the silk collar were like priests and educators.
They must have had a union, those leather collar guys.
I imagine that they did. And then they stratified it also by religion. And unfortunately, if you were a member of Faith of the Seven, your likelihood of dying was much higher than if you were a member of the Great Stallion or Lord of Light religions, as well as the last known allegiance. And apparently, can you guess which allegiance conferred the greatest likelihood of death? Matt, you haven't really watched this show, but
never seen the show.
Anyway, If you were a Targaryen, you had the next to lowest level, or a Greyjoy, you had next to the lowest level. But if you were a member of the Stark clan, if your allegiance was with the Starks, you had over 10% likelihood of dying in the show. And if it switched during the show, you had a 45% chance of dying if your allegiance did not switch.
Wow.
Why do we not think of things like this?
That is so clever.
I really want to be a member of the boiled leather collar.
I think on this podcast
great
you are,
paper.
Don. On this podcast you are.
So
Well,
wait,
that's
so wait,
the end of our-
wait.
Oh,
I
that
want
is
to get
not
back to
the
the
end of our-
ICD-9, the ICD-10 codes, because we earlier on in the series we learned about being hit by ducks as a new ICD-10 code, and I'm wondering if there's like a code for like incinerated by dragon. Or boiled in oil, or things like that.
No, bitten or struck by dog, bitten or struck by other mammal.
That would
There's
be
nothing
other.
in here.
Are dragons
duck.
mammals?
No, they're not.
Are
They're I'm sure they're reptiles.
Okay, but they're hot-blooded. Yeah.
There's an ICD-9 code for legal execution. Did you know that? Asphyxiation, maltreatment syndromes. Other ill-defined or
Wow.
unspecified causes of mortality. Apparently, nobody dies of old age in Game of Thrones.
Oh, no, it's too, they've got too much to do. That is awesome, Don. Thank you for. I think
was
you win the prize on
excellent.
that
That
one.
is so cool.
That's great.
So cool. All right, well, that's the end of our program. If you got any feedback on this or any other episode, or you want to suggest a topic or a study for us to take on, you can tweet us at @PopHealthyX, or you can tweet me at @ProfMattFox, or Chris at id.gill, or Don at dtheo1. Or as always, you can find us on the Population Health Exchange website at www.pophealthex.org. We want to thank Leslie Talalian, Director of Lifelong Learning at the BU School of Public Health, for supporting the podcast. And as always, right there in the studio, Nick Guler, for his tremendous and unending work of sound and editing to make us sound good. Thank you for joining us. We hope you enjoyed it. And we sincerely hope that you will download our next episode.